Hello, good morning, everyone. Today we are going to start a new unit, which is the cardiovascular system in the orientation class. Now, in the orientation class of the cardiovascular system, what we are going to understand, because this class is for the beginners. So, here we are going to get oriented to the essentials of the cardiac system. Now, in the cardiac system, the structures in cardiovascular system, the structures involved. What are the structures involved? They are mainly the heart, of course, the heart. Then we have the blood vessels, right? These are the main structure which are involved in the functioning of the cardiovascular system. Now, what is the main function or purpose of this cardiovascular system? As a whole, I'm telling. The function of the cardiovascular system is to carry out circulation. So, the heart is contracting and relaxing and it is pumping blood to all the structures, including itself. Now, this circulation, why is it important? Because through this circulation via blood, okay, so heart blood and heart blood vessel and blood are the main or essential components of the cardiovascular system. Now, via this blood, what happens? The essential nutrients are supplied to the cells of the body. Okay, this is the main function of the cardiovascular system. And who are the players? What are the structures or who are the players in it? The heart, the blood vessel, and obviously the blood, because it is getting circulated and it is doing the function of the cardiovascular system. Now, the essential structure of the center point of the cardiovascular system happen to be the heart. Now, heart is the main organ or structure in the cardiovascular system. So today what we are going to do? Today we are going to understand the essential structure which is generating and causing the mechanical action of the contraction and relaxation of the heart by the heart so that the cardiovascular function can be carried out. Now, we know that from very school life, we know that the heart, the heart has the capacity to generate impulse. So every time the heart is beating, that is contracting and relaxing, it happens due to the impulse that is generated. Now, when I talk about the impulse, impulse means action potential or the electric event. Electric event. Now, this impulse, which is also the electric event, leads to mechanical process that is contraction and relaxation of heart. This is what is happening. Now, this impulse generation in the heart is not only the capacity of only one structure in the heart. It is not only the capacity of one structure in the heart. The heart has a backup in such a way that more than one structure in the heart can generate impulse. So, getting started with that. Now, understanding the conduction system of the heart. Now, heart is what? It is made up of a muscle which we call as a cardiac muscle. Now, all these structures which are present within the heart and is capable of generating impulse and also conducting the impulse. Generating impulse as well as conducting impulse. All they are modified cardiomyocyte. So, these are the modified cardiomyocytes that act as impulse generator and impulse conductor. Okay. These are nothing. It's not like something which is not cardiac muscle. These are cardiac muscle only, but they are modified. So, such impulse conducting structure are multiple. The impulse generating structures of the heart are number 1, SA node, number 2, AV node, number 3, bundle of His, and number 4 is the Purkinje fibers. Okay. Now, all these structures that we are talking about, they generate the impulse at a particular speed, at a particular rate, like this many times per minute, it will generate the impulse, right? Cause the action potential firing, generate that electric action potential. So, SA node does it at the rate of 70 to 80 times, which we call as beats per minute, that impulse. Okay. AV node does it at the rate of 40 to 50. Okay, at this point, let us better not write the beats. We'll come to that, correlate and come to that. So, 70 to 80 times per minute, because here we are talking only about the electric impulse, right? We'll come to this later, the beat part of it. With 40 to 50 times per minute, where it's bundle of hills. It is like bundle of hills and Purkinje fiber, they are much more lower. It is about like 15 to 40 times per minute. 15 to 40 times per minute. Now, this range that I am saying, it may go a little up and down. Like it may so happen, SA node in a person, it may, in normal condition, may also generate few beats more than 80 up and down. Okay. So, it doesn't mean that it's not functioning abnormally, because all this thing depends on a person's stature, a person's body quality, age, height, all these factors are there. But this is the general rate or times at which this impulse are generated. Now, from all this, we can see it is the SA node that is giving out the firing maximum time, highest number of time. Therefore, it is the natural pacemaker of the heart. It is the natural pacemaker of the heart. Now, where is this structure located? Very quickly, we will go through the location of this structure within the heart. So, looking at the structures, so this is the structure that we are going to use now. Okay, okay, so zooming it out little bit. Okay, the first structure that we mentioned is the SA node. This is SA node, and this one is our AV node. Now, talking about the SA node and the AV node, where are they located? So, SA node, it is located at the orifice, at the meeting point, or at the junction between the right atrium and superior vena cava. This is where the SA node is located. Where is AV node? AV node, where is it located? It is located posteriorly near or very close to the intra-atrial, as you can see, intra-atrial septum. Okay, that is on the right side of the intra-atrial septum. These are the location of this two nodes. SA node we have already seen. Functionally, it is called as the body's natural pacemaker. So, why SA node is called the body's natural pacemaker? It is also a very common MCQ point. So, SA node is the body's or heart's natural pacemaker because of its steepest. It has got the steepest pre-potential. Now, what is steepest pre-potential? That we will understand with the graph. For now, we'll understand like after a few minutes with the graph. Now, for now, just remember the phase that causes the generation of the impulse. It is steepest. It is the slope is like steepest in the SA node compared to the AV node or the other structure. And also, because of the overdrive suppression. Okay, these are the two main factors because of which the SA node is the heart's natural pacemaker or body's natural pacemaker. Whereas this AV node, it also has a function. AV node, it is called as the gatekeeper. Like when the impulse comes from the SA node to AV node, it holds the impulse from some time. Okay, that's why it is called the gatekeeper. It is regulating the speed of the passage of the impulse from AV node to the subsequent structures. Next structure that we see, like here, this is the beginning of the interventricular septum. From the interventricular septum, as we can see, there is bifurcation on the right and the left side. So, what originates from the AV node is the bundle of His. Bundle of His. So, these are the bundle of His, and they bifurcate and rather form like fascicles. Also give out branches like fascicular branches that penetrates all the way to the posterior basal part of the ventricle on either side. Okay, these are called the Purkinje fibers. Now, bundle of His and Purkinje fibers, they are both the important structure in conduction of the impulse, and they can also generate the impulse. Okay. So, yes, Dr. A, it gives time to the delay the impulse. Yes, that is what the AV node does. Okay. Only when the AC node is unable to generate the impulse, that is where the AV node comes into play. Now, when AV node is not able to generate the impulse, still the heart does not stop beating, though the rate is very slow. Then it is the bundle of His and the Purkinje fiber that will give out the firing at a much slower rate, but it will still generate impulse. Okay. The main target of the heart is to never stop beating. It does not want to stop beating. It keeps on, wants to pump blood to the circulation. Now, as I mentioned, like about the gatekeeper role of, wait, I'm Dr. AAA, right? Wait, just hold on. After this, I'm coming to the gatekeeper role of the AV node. Now, AV node causes nodal delay. What is nodal delay? It means the impulse that comes from SA node. What it does, it gets delayed, like immediately as soon as it reaches the AV node, like from SA node to AV node. SA node is generating the impulse. As soon as it generates, it is directly passed on to the AV node. By what? That also will come. But after it comes to the AV node, immediately from AV node, it does not pass to the bundle of His. It does not pass to the bundle of His. So, here the impulse, it will gets delayed by 90 milliseconds. Roughly like 1 second. It's less than 1 second, but roughly. It's like about 90 millisecond the AV node is keeping the impulse within itself. Okay. This phenomenon, this is called as this delays the conduction of impulse to bundle of His. Now, this phenomenon, this whole phenomenon, this is what is called as the AV nodal delay. And what is the clinical implication, or the not clinical implication, rather the applied part of it? Why? Why does the AV node delays that one? It is because of the, what is the applied part? It is because of AV nodal delay. The ventricles get enough time to repolarize. Like from the previous beat, when the impulse have come and it has caused the action potential past the depolarization wave to the ventricle, because ventricle mass is big compared to that of the atrium. So, it is only because of the AV nodal delay that the ventricle gets enough time to repolarize and relax. Okay. What is the difference between bundle of His and bundle branch? You mean bundle bunch, like, okay. Bundle of His, it is the mother of the conducting zone. Now, this Purkinje fiber, it branches off left side, as you can see, I have not marked, but you can see left side and the right side, it has branched into two branches. Now this bundle of his, it again like bifurcates into thin finer fascicle that I have drawn with a blue pen. That thin fascicle, that is going up, this fascicles, that is like branching off and going all the way till the posterobasal region of the, like the posterobasal region of the ventricle, that blue subdivision, that is the left and the right. On the left side it is called the left, and the right side it is called the right bundle bunch, the offsprings that comes out from the Purkinje fiber. And bundle of His, it is the main structure that originates from the AV node, and from the bundle of His, the left and the right division splits out and forms the bundle of this Purkinje fibers. Understood? So bundle of His, it is the main bundle from which this Purkinje fibers and the fascicle, that is the bundle bunch, are formed. Okay, this is the importance of it. Okay, so applied part of the AV nodal delay is over. Okay, now one thing that needs a mention very quickly, because this also comes under anatomical part, which I'm sure you know. So here the SA node is the impulse generator, right? It is generating the impulse. Now from the SA node to AV node, how will the impulse pass? Yes, the whole of the cardiac muscle that has got cardiomyocyte. Now point to remember, whole of cardiomyocyte can conduct impulse, but the rate, means the speed, is slow. Okay. Therefore, there is presence of this internodal. SA node is a node, AV node is a node. So between SA node and AV node, there are this internodal bundle branch. Okay, internodal bundle branch. So this posterior one, the posterior one, it is called as the internodal pathway of the thoral, the posterior most. The intermediate, the middle one, is called the internodal pathway of Vanky back. And the anterior most, it is called the internodal pathway of Bachman. Okay. Now, from the, this is the right atrium where the SA node is located. From the right atrium to the left atrium, there also the impulse is passed via the anterior bundle of the internodal pathway of the Bachman. Okay, and these are all, this we will study in details in, means all of it we will have an idea through ECG in tomorrow's class. Okay, this is how the impulse are like conducted. Okay, now after that, another important thing that we have to know is the rate at which this impulse is conducted. Rate means the speed at which this conduction of impulse take place. Okay, like from SA node, it has to come all the way to the AV node. The rate is 0.05 meter per second. Now from the AV node to the bundle of His, it is very slow, rather slowest, 0.0 to about 0.02 meter per second. I'm keeping gap because we will write about it. Then through the atria, atria also has cardiomyocyte. It is relatively faster. It is 1 meter per second. Through the ventricles also it is faster, same. and it is fastest to the Purkinje fiber. Okay, it is really, really fast. Now, what is the reason? What physiological adaptation has happened in the AV node? That the impulse is conducted at a slower rate. Now, here the number of gap junctions are less. They're very, very less. Now, gap junction is a structure through which the impulse can literally jump from one region to another region, and it is a characteristic structure, physical structure of a cardiac muscle. Now, in AV node, this is very, very less compared to the other structure. This is one reason. This is one reason. Another reason also, the action potential in the AV node, we will study about the cardiac potential right after it, is of slow type. This is another one. Third reason, the diameter of the cardiac muscle fiber is small. So since the diameter of this cardiac muscle fiber in the AV node is small, the impulse conduction will be slower. So all these three factors makes the impulse conduction very, very slow. Whereas in Purkinje fiber, why it is fastest? Obviously, the reasons are opposite. The gap junctions are highest. They're very more in number, much more in number here. That's why impulse can hop very easily. They can get transmitted. Here, the action potential is of fast type. That we will study in the cardiac potential. What is slow, what is fast. And also the diameter of the fibers are larger. So larger diameter, speedier or faster is the conduction of impulse. So this is the reason, these are the reason which makes Purkinje fibers the highest conductor in terms of speed, and slow conductor is the slowest conductor is the AV node. Now coming to the innervations. Innervations to the heart. After that, we will study how the beats correlate roughly to the ECG tomorrow in details. Okay, the innervations to the heart. So, this especially when we are talking about the innervation, we mean the innervation from the autonomous nervous system. So, both sympathetic and parasympathetic nerve fiber innervates the structures of heart. In that also, there is a thing that we should remember. SA node, AV node, ventricles and atria receives sympathetic innervation. Point to remember a high yield thing, very important thing. No vagal motor nerve, no vagal motor nerve innervates the ventricles. Means this sympathetic innervation goes and innervates both the nodes and all the structure like in the atria and the ventricle. But parasympathetic innervation, it is confined only to the SA node, AV node and the atria. Okay, only the SA, AV nodes and atria receives vehicle motor innervation. This is a point to remember. Ventricles have got no innervation from the vagal branch of the parasympathetic nerve. Now, what are the different effect of stimulation of this sympathetic and parasympathetic innervation? So, before that, we have to remember the sympathetic innervation is in the epicardium and the parasympathetic innervation is in the endocardium layer of the heart. Means the innermost layer, it receives the parasympathetic branch and the outermost layer, it receives the sympathetic branch. Now, coming to the SA node and the AV node. Now, we know that the SA node, it is like more onto the right side, right? More onto the right side. So, SA node and 2AV node. So, 2SA node and 2AV node. SA node develops from the right side of the embryo when it is differentiating. So, here, right vagus, right side of the vagus, and that is a sympathetic innervation and parasympathetic innervation and sympathetic innervation, right stellate ganglion. That is the branch that goes to the SA node. To the AV node, left vagus, left side of the left branch from the vagus, because it is a left-sided structure, the AV node comparatively it is a left-sided structure, right? Left vagus and the left stellate ganglion. These are the innervation that they receive. Now, if there is stimulation to the right vagus, because vagus has two-sided branches, one is on the SA node, another is on the AV node. So, SA node, it receives the right side innervation from the vagus, right? The vagus right nerve goes to the SA node. So, stimulation to the right vagus. Now, vagus nerve, it is inhibitory. Its effect, the parasympathetic effect on the heart is inhibitory in nature. So, stimulation to the right side of the vagus nerve causes decrease in the heart rate because the impulse generating capacity in the SA node, it becomes slower when vagus nerve is stimulated. Okay, right vagus nerve is stimulated. Whereas when the right stellate ganglion is stimulated, stimulation to the right stellate ganglion, that is the sympathetic branch, right? What will happen? It will cause increase in the heart rate. It will cause increase in the heart rate. Opposite will happen in case of stimulation to the left vagus. So here, stimulation to the left vagus causes. Now, what is the function of the AV node? AV node is not generating impulse. It is conducting the impulse. It is conducting the impulse. It is the gatekeeper. As it is, AV node is causing little delay in the conduction of impulse. Now, when the vagus nerve is stimulated, it will cause more delay. It will take more time. So, it causes delay. It causes delay in conduction. Conduction of what? Obviously impulse. Okay. If opposite happens, if the sympathetic innervation is stimulated sympathetic innervation always increases parameter. Increases parameter means heart rate will increase, conductivity will increase, excitability will increase. All this cardiac function will increase when sympathetic innervation is stimulated. So if left striate ganglion is stimulated to left striate ganglion causes faster conduction of impulse. Faster conduction of impulse. So overall, what we have to remember, this is like high yield thing. This is a main take of it. Overall, what we have to remember, sympathetic innervation stimulates the cardiac functions and parasympathetic innervation inhibits the cardiac function. Now, there are certain terminologies that we use to understand when the heart rate is increased, the conductivity is increased, all these things are increased. So, it is as like ionotropy. Ionotropy, then we have chronotropy, we have bathmotropy, and we have chromotropy. We also have lucitropy. So, ionotropy means the force of contraction. So, force of contraction is termed as ionotropy. Chronotropy is the heart rate. Bathmotropy is the excitability. Chromotropy is the conductivity. And lucitropy is the relaxation. So, when there is increase in the force of contraction, when the sympathetic innervations is stimulated, it is called as the positive chronotropy, and opposite is negative. Similarly, when the heart rate is increased, we call it positive chronotropy and negative chronotropy. Force of contraction, positive ionotropy, decrease negative ionotropy. Same. Positive bathmotropy, negative bathmotropy. Positive dromotropy, negative dromotropy. And positive lucitropy and negative lucitropy. So these are the terminology that we use to designate or make us understand whether the cardiac function has increased or decreased. So this terminology and what it exactly means needs to be remembered. Okay, so this is like the basics and the like understanding the conducting system of the heart. Now, the pathway of the wave of depolarization and repolarization. Like we know the wave of depolarization is electric event. in heart is it is from the endocardium to, I'll show the diagram also, epicardium. Means the depolarization first starts with the innermost layer. Innermost layer, that is the endocardium. Then it moves to the epicardium. Whereas the repolarization wave is in opposite direction, is from the epicardium to the endocardium. Okay. In this context, we'll just see one picture. This is okay. So as we can see in this picture, okay. So here, if you look at the picture first, the wave of depolarization, it has begun from the SA node. It has begun from the SA node. Now, from the SA node, it goes via the internodal pathway to the AV node and also to the left atrium. So, from left atrium, it goes to the AV node, SA node to AV node. Now, from there, through the bundle of His, it goes and starts moving. Now, the first structure to get the wave of depolarization is always the left endocardium. Is the left endocardium, then it swaps the major part of the left ventricle. Remember, the left ventricle receives the depolarization wave little early. Then it goes to the right ventricle. But the contraction is little bit faster, little bit earlier in the right ventricle. That we will come when we study the cardiac cycle. So once it comes and swaps the major part of the ventricles, after that it goes up like through this fascicle. See the fine branching through the fascicle, it goes late and lastly to the posterobasolateral, the topmost. From the tip, it goes again to the topmost part posteriorly, basolaterally, and then the wave of depolarization stops. So here you see it started from the innermost layer, that is the endocardium, and it went up to the epicardium. So depolarization is from endocardium to epicardium. But when the repolarization sets in, the wave of repolarization starts like from the epicardium and then it goes to the endocardium, just the opposite direction. Now, as you can see, when the major part of this atrium has received the wave of depolarization, it is designated as this P hum. So, until the half of the P hum, actually the atrium are depolarized and the impulse is passed to the AV node. Now, this dash that you see, that is what is the passage of the impulse from the AV node before the ventricles have actually undergone depolarization. So, of course, tomorrow we will discuss all of it again. So, R is the beginning of the depolarization. Here, actually, the initial part of the bundle of His gets depolarized. And when the major part of the ventricle is getting depolarized, we get the R wave. And ultimately, when the posterobasal area, that is the topmost area, that is swapping backward, then we get the negative deflection S. So, QRS is the complex of the ventricular depolarization. And lastly, it is followed by the ventricular repolarization D. Okay, this is how it is reflected on the ECG. Okay, now moving on to the cardiac potentials. So, what is cardiac potential? Cardiac potentials, very in a fluid manner, crisp manner, and a clear concept laying purpose, we will study it the way we are going to study now, because this is the way that will enable us to remember. Just now we have seen that though heart is a single structure, but not all the structures of the heart, they are structurally and functionally similar, right? Overall, all of them are undergoing electric response and showing mechanical response, right? But still there is some difference, right, in the conduction, in the generation of impulse. Now, that is because the action potential that is generated in the structure of the heart, they are not of one type. They are of two types. So, action potential, this is of two types. Okay. One is the fast response. Another one is the slow response. Generally, what did we see in the skeletal muscle and in the nerve cell? The action potential was something like this, right? This. But here, that is what we saw there. So here, it is not like that. The fast response is something that look like this. And the and the slow response is something that looks like this. Okay, now the structures in the heart that shows the fast response is seen in the atria, atrial cardiomyocyte, the cells of the atria, ventricles, and Purkinje fibers. Okay, whereas the slow response is the nodal potentials, means in the SA node and AV node. Okay, so this is the type where we see. Now, understanding the different phases in this action potential and what are their ionic phases. So, we start with the fast response. This is our fast response diagram, action potential. Okay. So, in the fast response, which is seen in the atria, ventricle, and Purkinje fibers, there are like 5 stages. There are 5 stages, like phase 0, that is at upward stroke, and that notch that is seen, it is phase 1. The plateau, the sloping area, that is phase 2. The downfall is phase 3, and the flattened one is phase 4. Okay, they are like 0, 1, 2, 3, 4. Now, what is the nomenclature of it, and what is the ionic basis of it? So, phase 1, phase 0. Let's start from phase 0. It will be easier. Phase 0, it is that the upward stroke. This upward stroke that we can see here. It is the depolarization. Just simply depolarization is a one-liner we have to remember. It is nothing but it is our wave of depolarization. Now, what is the ionic basis of it? The ionic basis is like same like that of what we studied in the nerve cell and the muscle cell. It is sodium influx via the voltage gated channel. Now, what is its clinical implication? Its its clinical implication or the applied part is that this channel can be locked by tetrodotoxin from pufferfish and also by other anti-arrhythmic, drugs. Coming to the second phase, that is the one. In one, what do we see? It is just a notch. That notch itself is the stage 1. That is the second phase. Now here, this second phase, that is the phase 1. This is the repolarization beginning. Beginning of the start of the repolarization. So here, what is the ionic basis of it? The ionic basis is closing of voltage gated sodium channel, and that is the voltage gated sodium channel are closed, so no influx is totally stopped, because sodium voltage gated channel, as we studied, they open also fast and they close also fast. So here what happens? The potassium efflux starts, and the clinically important or importance of this region is that drugs like 4-aminopyridine can lock these potassium channels. So actually, the resting membrane potential, as you can see here, the resting membrane potential of this is about minus 70, right? Sometimes it is like a little bit upper also or lower also. It reaches to a maximum. Of plus 30 to 35 MV, and then the notch, the repolarization starts. The third phase, it is the phase 2. The phase 2 or plateau phase. Now in phase 2 and plateau phase, what happens? This is also the repolarization. As you can see, here you see a plateau. This is also a repolarization phase. So in this repolarization phase, the L-calcium channel. The L-calcium channel means the dihydropyridine receptor calcium channel, means the voltage gated calcium channel opens, and influx of calcium happens. When this is happening, potassium efflux continues. Potassium efflux is happening, but calcium channel has opened. So here the influx of calcium happens. Now, what implication does it have in the clinics? Drugs at this stage, drugs like verapamil cardiac can log these calcium channels. Okay. Now, after the plateau, that is the phase 2, there is a rapid downfall. There is a rapid downstroke. This is the phase 3. So, next is the phase 3. So, what happens in phase 3? Now, here, L calcium channel, which is again voltage gated calcium channel, which is again the dihydropyridine calcium channel, closes down. Okay, so there was influx of the calcium happening. Now the channels have closed down. Now no more influx of calcium happens. But still, some channels would still be open because calcium channels are also very slow to close. So there is like little bit of influx of the calcium. Okay, but not like rapid as it happened in the phase 2. And here, because so much of calcium has increased, potassium efflux happens rapidly via the rectifier channels. So potassium has this outward rectifier channel, inward rectifier channel, transient rectifier channel. So through all these rectifier channels, the efflux of the potassium happens, so that all the positive charge, as much as positive charge that has entered, should be again thrown out of the cell, because the cell is now repolarizing. And remember, in this fast response is in which structure? It is in the atria and ventricle. And ventricle of the heart is very important because it receives the blood. It receives the blood. It fills up with the blood that the ventricle has to pump to the periphery. So if the filling phase of ventricle is not proper, if the repolarization of ventricle is not proper, then we will not have enough blood to pump to the periphery, and immediately the person will have decrease in the blood volume. Okay, so this phase of repolarization, relaxation of ventricle is very important, which we will again emphasize on when we study the cardiac cycle. So phase 3 causes the efflux of the potassium, and the calcium channels, like 90% of them has closed down. Only few are very open, which are like which is closing very slowly. Okay, now next comes the last phase, which is the phase 4. That is the resting membrane potential phase. So, phase 4. It is the resting membrane potential phase. Like after depolarization, repolarization, now it has to come back to the resting membrane potential. One thing here we have to see that unlike what we saw in the skeletal muscle fiber and nerve fiber, the repolarization is not something that is going down like that, right? Going down like that. No, this never happens. There is no hyperpolarization in case of resting membrane potential laying phase in case of this cardiac muscle of the atria, ventricle and the Purkinje fiber. So here what happens is that again efflux of potassium slows down. Okay, then the calcium conductance is almost minimal, or it almost shuts down, and the sodium potassium ATPase, it pumps, sodium potassium ATPase, it pumps to restore the resting membrane potential. This is what it happens. So these are the 5 phases of the fast response in the cardiac muscle, that is the atrium and the ventricle. Now this is what the muscle show. The next one is the slow type response. The slow type action potential or the response. The slow type response is like we'll discuss with the phase. Oh, I just changed the picture. This picture is not very clear. So let me select another picture. No. Now this slow type of action potential, it looks very different. And the ionic basis is also very different. Now, this is the action potential that is seen in the nodes. Nodal potential is a node and AV node, only in these two. We don't see this type of action potential in any structure of the cardiac muscle. So, the phases or the stages of the action potential here is like, here first the resting membrane potential that we see is like negative, because AC node and AV node, the resting membrane potential, the RMP of the nodes are usually like -50 to -60 millivolt. That's where the resting membrane potential is. Okay. Now here this phase, just see this very steep, gradually rising phase. This is what is called as the phase 4. Phase 4. Okay. Then the upward stroke that is above the threshold stimulus, that is called the phase 0. And there is no phase 1, there is no notch, there is no phase 1, and phase 2 and 3 are kind of merged. In some diagram, in some condition, like in some graphs, there may be like something like this also, like little bit this also, in which case we say this is phase 2 or this is phase 3. But overall, we may take this phase 2 and 3 together, like clubbed up, and call is like phase 3. So in the slow type of response, we have only 3 phases. One is the phase 4, then is the phase 0, no phase 1, no incisura, no like a sharp starting of the depolarization. But this phase 2 and 3 are kind of clubbed up together, merged, and it is called as the phase 3. Now, what is the ionic basis of it? This is a very interesting point to understand. So let's start with phase 4. Now phase 4, it is the pre-potential. It is the pre-potential, or it is also called as the pacemaker potential. It is called as the pacemaker potential. So if you see here in the phase 4, it is the resting membrane potential is rising. It is kind of rising. It is not like how we saw in the skeleton or the nerve fiber action potential, which was steady. So the nodal pre-potential is always like in unrest. It's always in the unrest. It is not resting. It is not lying static in one position, right? What is the cause for it? The ionic basis for this is that here at hyperpolarization. So here you see the resting membrane starts from -60, which is like hyperpolarized condition, right? Means that is below 0. So at hyperpolarization, the hyperpolarization induced sodium channels open up. Okay, there are certain sodium channel which are not the voltage gated sodium channel, but these are some different kind of sodium channel which will open only when the resting membrane potential is like negative, is like below zero, is hyperpolarized, negative, below zero. Okay, unlike the other voltage gated sodium channels that we have seen. So this hyperpolarization induced sodium channel, it will open up and there will be sodium influx at slow rate. Now, when there is influx of the sodium, here you see there is a gradual rise from negativity to less negativity, means from negativity to positivity, it is increasing. It is gaining like Na plus, which is positively charged. So the negative charge from negativity, it is increasing to positivity because minus 60 is more negative than minus 30, or minus 30 is more positive than minus 60, right? So sodium influx, because of the sodium influx, there is like increase in the positive charge. This is one reason. Now, whenever any positive charge comes or leaves, it will always cause a change in the current. So sodium influx in this stage, that is in stage 4, causes a generation of current which is called as the funny current. Funny current. Okay, it's designated like that. So why it is called funny current? It is called funny current because this current is generated. It's very funny that it is generated only when the cell is in hyperpolarized condition. Cell is in hyperpolarized condition, which is a very funny event, which is not the normal event. That's why it is called funny current, and those sodium channels are also called as the funny current channels. Okay, this is one factor. Another factor, when this is happening, here, there is also some transient calcium influx. That's why I am using a downward arrow. So here it means influx. It means influx, not decrease or increase. Here it means influx. So there is influx of the calcium through the transient channel, not the dihydropyridine voltage channel. So via 3 channels of calcium, influx of calcium happens. Where? In the phase 4, which is the pacemaker potential. Means the resting membrane potential is rising to cause the firing from the SA node. Okay, so one factor is the calcium, second is the influx of the calcium, first was the influx of the sodium via the funny current, to generate the funny current via the funny current channels. That is the 2 reason. And third reason is that here here the potassium efflux, is very less in phase 4. In phase 4, potassium efflux is minimal. It is not stopped because potassium has a leaky channel through which there is always movement of the potassium. So efflux of the potassium, that is loss of the positive charge from the cell to outside, becomes very less. Rather, what happened? Sodium is entering, calcium is entering. 3 events: sodium enters, calcium enters, and potassium leaves very slowly. So all these things decreases the negativity and makes it more positive or less negative. So from minus 60, it went all the way up to minus 30. Now, as soon as it went up to minus 30, it gets the threshold. Then what starts is our phase 0. Here, the phase 0, it is the depolarization phase. This is the depolarization phase. Now, here the ionic basis is that, unlike the fast type of response, here the ionic basis is that in the 0 phase, there is no influx of sodium. Sodium plays no role in the depolarization of the SA node and the AV node. Here, influx of calcium through the voltage gated or L type channels occur. That is the dihydropyridine. Through that, the influx of calcium occur. That's why the SA node depolarization cannot be blocked. Here the clinical implication is that tetrodotoxin cannot block calcium L type channel. So SA node has no effect from the toxin from the puffer fish. Now, there is no phase 1. Phase 2 is merged with phase 3. So, what happens in phase 3 now? Phase 3. It is the repolarization phase. So, in the repolarization phase, what happens? What is the ionic basis? Here, the ionic basis is that potassium efflux starts and calcium influx stops. That means L type channel closes down. Okay, this is the ionic basis of this phase 4. Now, what is the phase 4? The ionic basis of phase 3, that was. So, phase 4 again, that is the resting membrane potential relaying phase. So, here again, after the repolarization, here now once again what happens? Here, the ionic basis is that obviously the potassium conductance slows down, okay, and the sodium and calcium exchanger. Like what is happening here, this is what we started with. But since when we started the phase 4, we were highlighting on its transition from resting membrane potential to the depolarization wave. We mentioned about the sodium channel and potassium conductance, how it changed, how the sodium channel and the calcium channel helped in gaining more positivity. Okay, now the same phase 4, why we are studying it again as resting membrane potential relaying? Because it is like after it is the sharp decline from phase 3 and the beginning of the phase 4. Like action potential is over, the repolarization phase is also over, repolarization. Now again, it is the start of the phase 4. So at the start of the phase 4, after phase 3, what happens is that the efflux of the potassium starts to slow down and the sodium calcium exchanger starts acting. So here what happens? One calcium is effluxed or rather pumped out. It is an exchanger, so the term pumping out would be more appropriate. Is pumped out. Out means out of the nodal cell. And the sodium molecule is pumped in. Now again here, what will happen? The sodium potassium ATPase will act to balance the electric neutrality. It will act in such a way that the 3 sodium that is pumped in is again proportionately pumped out to maintain the electro neutrality within the nodal cells. And after that, after it has like balanced it, then again the sodium influx via the hyperpolarization induced sodium channel will start. Okay, the prepotential will start. So here what we have to remember, altogether we have to remember that phase 4 is the prepotential phase. It is the pacemaker phase. It is a restless phase. It is not a linear phase. Why it is not a linear phase? Because when it has touched the maximum negativity, the hyperpolarization induced sodium channel open, sodium comes in. Sodium comes in, calcium also comes in, but via the transient channel, not the voltage gated channel, via the transient channel. When these two are happening, potassium also very less in quantity, efflux is carried out. In for the potassium in very less quantity leaves the cell. So all these three factors makes the nodal cell resting membrane to less negative. So if it was minus 60, it goes to minus 30. So minus 30 is where it minus 30, minus 35, this is where it gains the threshold stimulus. Once it gains the threshold stimulus, it shows depolarization, the firing. Firing of the AC node and AV node is caused by influx of the voltage, influx of the channel through the voltage gated calcium channel. Influx of calcium through the dihydropyridine channel or L channel. L channel. Okay, after it reaches maximum positivity, which is about plus 10 millivolt, again this calcium channel closes down, efflux of potassium happens. Efflux of potassium happens very rapidly. Now, efflux of potassium happens so rapidly that it goes all the way back to minus 60. Okay, now to bring it back to minus 60, only efflux of potassium is not enough to start the phase 4. What is needed? The beginning of the phase 4, what is needed? The calcium that has entered so much within the nodal cell, that excess calcium is removed by the sodium calcium exchanger. Sodium calcium exchanger. And the extra sodium that has come in is also now balanced by pumping of the sodium potassium ATPase. Now all these things together, when it once again takes the resting membrane potential to minus 60, again the same phenomenon starts again. Like the funny current channels will open up. Again the K plus conductance will be less. Again, the calcium will enter via the transient channel. The whole cycle will be repeated. So, this is our slow type of response. Now, what is the clinical link of it? What are the two clinical implication of it? Like clinically, it is seen that the clinical link. Now, in patient with patient with coronary artery disease. Suppose there is a blockage or there is obstruction in the coronary artery. What will happen? Blood perfusion will be less to the affected area. Like the coronary artery, which is supplying a particular part of the cardiac muscle, that will supply now less blood because of the blockage. So it will cause death or necrosis of the affected cardiac muscle. Now, when there is death of certain area of the cardiac muscle, what will happen? The potassium concentration in the interstitial fluid will increase. So when the interstitial fluid has more of potassium, that means from inside of the cell, because it is dead, the potassium has jumped out to the area near the dead area, which is not dead, that has accumulated in interstitial space. So now there is like less of this negative charge inside the affected area, right? So that particular area there, the ventricle muscle, what type of action potential do they show? They show the fast response. Now this fast response will change to low response. Okay, this is one example. So if there is like any blockage in the coronary artery, then that particular area will not receive enough blood. If it is not receiving enough blood, that particular area, the muscle tissues will start dying. So the potassium concentration will jump out of that necrotic area and get accumulated in the interstitial space. And this will change the fast type of response into the slow type of response. This is one condition. Another condition which we will again study tomorrow when we are studying the ECG, I'm just mentioning it here now. Another example, example 2, this was example 1. Suppose there is any generation of extra bundle in the pathway of conduction. What it will do? It will cause pre-excitation. Okay, it will cause pre-excitation. So here, suppose, so here, suppose I'm drawing the like heart for our understanding purpose. Okay, so these are the chambers of the heart. So now here what we know, from the SA node to AV node, the impulse is transmitted and this impulse is passed onto like the left and the right side via the bundle of His and Purkinje fiber, and then it dies off. Now if there is an extra bundle, accessory bundle, which has like generated in this, like here it is the left lateral region. So now what will happen? This wave of depolarization, after it reaches here, instead of dying off, it will again get recycled back into the ventricles. So when it gets recycled back into the ventricles, it will cause pre-excitation, means it will cause another wave of excitation even before the SA node has generated an impulse. Okay, even before the SA node has generated impulse. So presence of any extra bundle, which usually we call as the bundle of Kent, then after the normal beating of the heart, there will be another premature beating of the heart, because this accessory bundle will re-enter, cause one more entry of the current, and the current will go across the ventricle and cause pre-excitation, immature excitation of the ventricles. Okay, this is what will happen. This again, tomorrow when we study the ECG, we will study in context to the how it affects the segments. Okay, so till here I think you have now a vivid idea about the cardiac system, its conducting structures and how the conduction happens, and also its implied portion, and we have also discussed the cardiac potential in detail. So tomorrow I will see you and we will have a basic understanding, and also like with the clinical aspects and applied aspects understanding of the ECG. Okay, then see you tomorrow.